diagnosis of Alzheimer's and about the newest treatment we have for the disease. A few years ago, they actually came up with a few tests that prove that you have Alzheimer's.
Alzheimer's or dementia?
Alzheimer's.
Alzheimer's.
So, how long has Alzheimer's been around? Anyone have an idea? Forever. I like you. It was first diagnosed in 1906. No. It was diagnosed by a German physician. He studied his patient who had symptoms of dementia, and then after he died, he had an autopsy done, and at that point, he could see the plaques in the brain. That was the definitive diagnosis. How many of you want to volunteer for an autopsy to make sure you have Alzheimer's? Anyone?
No.
Yeah, I think we'll pass on that. So, guess what the physician's name was? Alzheimer's. Very good. Bingo! She wins the prize. So, yes, and he was a German physician. So, from 1906 until 2022, we didn't have anything to definitive said you have Alzheimer's. It was all really a good guess. Now, I shouldn't say guess. It was based on symptoms. Can we be wrong? You betcha. So what we did is we developed a few tests. The first one was called a mini mental status exam, and it's part of what the physician does in your annual physical, ask you a few questions, see what you remember. Remember those 3 words you're supposed to remember, and then they ask them later? Oh, that's fun. Let me tell you a personal story. 2 years ago, I was asked those questions, those 3 words. I couldn't remember one of them. I was sent off for that 3.5 hours of testing, the neuropsychological testing. How many of you have heard of that? Yes, because if you actually go for a diagnosis of the disease, that's what they've been doing. I can dance to the music. It's okay. Yeah, we can all growl at our phones. You're allowed.
I thought I turned it off. Guess what? I did.
You know what? I'm not sure mine's off, but mine's always on a vibrate. So guess what? You probably won't hear it. So I went for that 3.5 hours of testing. It was 2 years ago. 2 years ago this coming May. And so how long does it take to get results? Anyone remember? It's 5 to 6 weeks usually. And then to top it off, my neuropsychologist had a medical emergency, so it got delayed another week. So I went back to see her, and she says, you have a mild cognitive decline. Okay. And probably in 2 or 3 years, you will have Alzheimer's. Okay.
What was the first word you said?
Mild cognitive decline. We've heard that one before too, haven't we? Yeah. I went out to my car and I got behind the steering wheel and I literally banged on the steering wheel. And I looked up and it says, why did you give this to me? I know too much. I was devastated. It's the one disease I never wanted. So I started pursuing what's out there. I knew there were some clinical trials for new drugs. And the other thing I found out is to qualify for these drugs, there's some testing that has to be done. So we're going to talk about this testing. And guess what, folks? This testing tells you, yes, you do have Alzheimer's, or no, you don't. And you don't have to have an autopsy.
We're working on it.
We're working on it. We'll eventually have slides for you. So What you do at that point, what are these tests that can be done? You can have a PET scan. Now, a PET scan is a type of imaging. It's with a radioactive dye that is injected into your veins. And what it will show is the amyloid plaques. You have to have amyloid plaques to have Alzheimer's. So it can be a definitive diagnosis that, yes, you do have Alzheimer's. The other good thing about this testing is some of the drugs that we're using, it shows if they work. So there's some good reasons for the testing. Now, when I saw my neurologist and we talked about having a PET scan, the first thing I told her, I am extremely claustrophobic. I can't even get into an MRI tube. So she says it'd probably be better if you have a spinal tap. Anyone volunteering for a spinal tap? Oh, wait a minute. How many women here have had a C-section? None of you? Okay. It's not that bad, folks. It really isn't. Don't be afraid of it. So what they do, now, first of all, I'm on a antiplatelet drug, so I had to stop it for a week because they don't want you bleeding into your spine. And what they do is you go in, you lay on your side, a little curled up, and they stick a needle between the L3 and L4 lumbar vertebrae. But they do this in interventional radiology. Now, the reason for that is that shows the physician a picture of your spine. So he can put the needle in and not hit any bone. He can put the needle in and know exactly when he's into the spinal sac. And he can drain off CSF. CFS is cerebral spinal fluid. It is the fluid that circulates around your brain and down your spine. It does kind of this constant movement. What's around the outer surface of your brain? Amyloid plaque. So you end up picking up some of the amyloid plaque into your CSF. So they take that fluid and they test it for the amyloid plaque. They test it. Are we ready?
We're ready.
Do we have a way I can advance it?
I can advance it for you. Just nod your head.
Keep going. We talked about this.
Much better than me.
We talked about this one.
All right.
We're into diagnosis.
Okay.
We've done the PET scan.
Okay.
And one more. Oh, one thing I didn't tell you about PET scan. See, it's a good thing I do have slides. It's a nice reminder. This was approved by the Centers for Medicare to be paid. So if you're on Medicare, your PET scan's covered. Now, it doesn't mean you don't have a copay, but at least you're not paying $500, $600, $700 for it. Okay? And you can go forward a slide. So it was approved in October of 2023. Okay? And you can go forward again. Okay, we were talking about a lumbar puncture. So they're putting the needle in between the L3 and the L4. These are the lumbar vertebrae. Folks, your spine ends up here around L2, your spinal column. What does this look like? Anyone own a horse? Does that look like a horse's tail? It's actually called the cauda equina, which is horse's tail. And the thing is, when they put a needle in, they can't hit your spine. This is floating around in CSF. So if you come near one of these nerves, it's going to float aside. We can't injure your spine. You lay there for a couple minutes while they collect the fluid. It's not like a blood draw where they can draw back on it and draw the fluid out. They actually let it drain. They only have to collect about 2 or 3 cc's. And then they ask you to lay on your back for about 45 minutes, and you can go home. They do tell you there's a possibility of having a headache. If you do, lay flat, take some Tylenol. And you can't be active for a couple days. They don't want you doing anything strenuous. I mean, the first day I spent about the first day in bed because I wanted to be cautious. And the second day I was up and around the house. They don't want you swimming for at least 3 days. So it's not any worse than a blood draw. Don't be afraid of it. It's actually a simple enough test to do. So if you're like me and are severely claustrophobic, this is another way out. Now, the cost of a lumbar puncture, it can range about $1,000 to $2,000. Depends on how much your insurance covers. I don't know what your insurance covers. You know how much I paid? $65. And that was for the lumbar puncture and for the assay of the CSF fluid. I didn't pay anything for that. I've heard a lot of people have paid a couple $100 to have the results from that. My insurance, I have an Advantage plan, covered it all. So always check with your insurance company so you know what you're getting into. But these are all covered procedures under Medicare. This is the newest area. There is a blood test that can now be done. There's a couple problems right now, so keep your eyes and ears open. It has not yet been approved by Medicare for coverage. The other is it's not commonly done, so wherever you get it done, it's going to cost you an arm and a leg. What they do is they measure for the amyloid protein that's in the blood. Once again, you have this floating around in your brain. Well, you have blood cells. You have whole blood system up there. It's going to absorb some of it. You're going to find some of it in the blood. And the other thing probably you've heard of is the protein Tau, which is common for Alzheimer's. That can also be picked up in the blood. They are indicative of Alzheimer's. Okay, we'll do the next slide. Oops, you missed a slide. Your finger's too heavy.
I just saw.
So we have been for years doing clinical evaluations to diagnose whether a person has Alzheimer's. How accurate are we? One, who's doing the diagnostic? And two is, are there better things to diagnose with? Typically, an average private practice will be about 61% accurate. So that's almost 50-50, isn't it? You're taking a chance there. Please see a neurologist if you think you have a dementia disease. Clinical evaluations with somebody that specializes in the area, your accuracy goes up to about 73%. So with the blood test added to this, it's maybe another 10% accurate. The other two tests I was talking about have a 93 and a 94% accuracy. So if you really want to know if you have Alzheimer's, which test do you want to have done? That's your choice. Me? You're not getting me in a PET scan. You would have a screaming maniac. But what works for you, that's the choice. So from there, we're going to talk about some of the newest drugs. I'm telling you how to get a confirmed diagnosis that you have Alzheimer's. If you know that you have Alzheimer's, how do you want to treat it? Yeah.
What is the difference? What is the difference between dementia and Alzheimer's? Is it the same? So if you're seeing that cognitive
Decline.
does that mean really it's not dementia, it's going into Alzheimer's?
Okay, this is one area, this is an entirely different area of science. Okay, dementia is dementia. It's not necessarily Alzheimer's. Alzheimer's is dementia. Oh, now we're getting touchy. My father had a cerebral vascular incident occur when he had an aortic aneurysm rupture. So he had lack of oxygen to the brain. He was demented. He didn't have Alzheimer's. You can have a stroke and have types of dementia. We know that patients with Parkinson's, about half of them will develop dementia. There's a Lewy body dementia. There's a frontal temporal lobe dementia. So no, dementia is not Alzheimer's. The thing you look for on Alzheimer's, though, it's a progressive disease. The others are not as progressive as Alzheimer's. Alzheimer's, you may function independently for 2 or 3 years, and then you're going to need assistance. That progresses all to the point that you're bedridden. You can't eat or feed yourself. You're incontinent. That's the progression of dementia. That is Alzheimer's. Okay? My father was never incontinent. He just fell over one day in the living room and died. We know he had cancer and other things, but I mean, he never progressed to that point. But he was never cognitively with it. Wouldn't let that man behind the wheel of a car. Okay. Oh, you're welcome, and it's a very good question, and it's one of the tough ones to answer because there are so many different types of dementia. Okay, we have treatments we've been using for years. How many of you have heard of Aricept? How about Meminidine? It's another one. Exelon? Okay, all of these drugs are for symptomatic treatment. So they're working to help with the symptoms that you're having from Alzheimer's. So they boost memory by changing some of the chemistry in the brain. They don't do anything to slow the progression of the disease. You still have the disease and it's still going to trip right along, so you haven't changed anything. Now we have 2 brand new drugs. They've been out less than a year and a half. They are both IV drugs, and these drugs are called disease-modifying drugs. How did they get this name? They actually work to slow the progression of the disease. Oh, I got somebody's eyes open real wide. Yes, that's the point I want to get across. I could slow down the disease process with these drugs. Does that sound good? Mm-hmm. It's not as easy as taking a pill, folks. So we'll talk about all the things that are going on with this. They're better than those symptomology drugs. So your patient is going to do better. And they are actually removing some of the molecules of the amyloid plaque that are in the brain. Next slide. The drugs are Linquimbi and Kisunla, and they slow the progression of the disease. They do not cure Alzheimer's. We have not found that drug yet. We're still looking for it. But they'll slow or stop the progression as much as 30%. Those drugs we were talking about, Aricept, etc., they have a 12% improvement on symptoms. And that doesn't do anything with the progression. I can give you a third improvement on the disease progression here. That's good. Both of them remove amyloid plaque from the brain, and therefore that's why they're called disease modifying. It didn't like you. Leqembi or lecanemab is an IV drug. So this is not a pill that you're going to be able to pop at home. What these drugs do is they target the beta amyloid that's in the brain. They've been FDA approved. Typo error, sorry about that. The FDA approved it for early stage Alzheimer's. Does that mean if you're middle stage, you can't take it? No, you could probably still take it. We just don't think it works as well the further the disease has progressed. So that leaves you in that crevice. One, you want a diagnosis that's accurate, and you want it as early as possible. So if you have a family member that thinks they have a dementia and you want to confirm if it is or is not Alzheimer's, then you want to make sure that you know so that you can get him on these drugs. And this is what I was pursuing with my own history. I was looking at these drugs. When I had the LP done and the results came back, I do not have Alzheimer's. I wanted to celebrate. I wanted to dance across the earth. But you know what told me that was I had a spinal tap. It's worth it getting tested, yay or nay, to know the results. Do I have mild cognitive impairment? I'm an old lady here. My brain doesn't function as fast as it used to. What we know from Leqembi is that it slows the cognitive and functional decline by 27%, so around that 30% mark. It improves your quality of life by about 56%. Hey, I want to dance. That's hard to do with a bad knee. It reduces the amount of the amyloid plaque that's in the brain, in the blood, and in the spinal fluid. So it reduces that load that you have. This drug was approved in July of 2023. These are new drugs. Next slide, please. And Casinolaw, and I love their trade names, donanemab, they did an 18-month study. Now, what's interesting is none of these drug companies come out with information that is exactly the same as the other drug company. It's all compared differently. But in an 18-month study, they found that they had a 20% more slowing in memory and cognitive ability versus those that were getting the dummy infusion. So if you ever heard of a clinical trial, they give you half the people get the real stuff and the other half get the fake stuff. So that it showed it had clinical evidence that it improved the outcomes. And this drug was approved last year in July. New drug. Next slide. So this is actually a slide that I swiped from the company. So what rights did I infringe on? Okay, within that population, people were less progressed in their disease and had better results, 35% average slowing. I'm not going to complain with those results. Next slide. You're going to like these results, folks. At the end of 6 months, people on this disease-modifying drug had a 61% reduction in the amyloid plaques. So they had a PET scan done, and they compared it to the beginning. And then at 12 months, 80% okay, I think I want to stay on that drug. And then at 18 months, they only had an 84%. So you can see that that curve is flattening out. Now, I don't know what you think of present day politics, but we got lucky, folks. They froze everything and nobody was allowed to tell you anything from any of these services. And then the judges stepped in and says, oh yes, I can. And in that couple week time period, they came out. The FDA has approved this drug for after the 18 months for long-term usage at a lower rate and at once a month. This drug is actually given twice a month. So, thank you, Lord. These are all IV. So we'll talk about how they're given. This one reduces the amyloid plaques, and it's seen on PET scans. And it slows progression of memory and thinking issues that are due to the symptoms of Alzheimer's. We've got some good outcomes here. So with any treatment of any disease, you have to figure if this is something you want to do. Next slide. So these drugs are actually covered by Medicare Part B. They're extremely expensive. Traditional Medicare you'll end up paying about 20%. Now, if you have an Advantage plan, it will probably cover a little more. So once again, you need to go back and see what your insurance company covers. If you have a Medigap policy of some kind, it could help out. So I can't tell you what you're going to pay for it. Next slide. I can tell you the maximum that you'll end up paying for it. Yeah, that's a wake-up call, isn't it? Casinolol is $32,000 per year, and that 20% to you is $6,400. A lot of money. Leqembi is $26,000 a year, so that's $5,200 to you. This is probably going to change and improve over time, but this is where we're at right now. Next slide. What are the risks of taking these drugs? The absolute most common one is a headache. I have a friend that's on these drugs, and when she goes in, they tell her to take Motrin before she gets her infusion, and she's okay. So it can be a minor problem. Now, some of the issues we talk about are temporary swelling of the brain or small spots of bleeding in the brain. Being a neuroscience nurse, this doesn't sound like fun, right? A lot of times we see no symptoms from these. The patient is asymptomatic. You get the drug once a month or once every 2 weeks, and a day or two after, these have gone away. So most of the time you're talking about a minor issue. In a rare cases, I'm going to stress the rare, you may have something that's more potentially life-threatening. So patients need to be monitored. So your primary care physician or your nurse practitioner is not going to prescribe these drugs. They don't want the responsibility. You do need to see a neurologist. They will see that you get the follow-up scans. Typically, these patients after the 6th dose have an MRI. When we do an MRI, we can't see amyloid plaque. What we are looking for are spots of swelling or bleeding. So we're looking for these symptoms. Nothing going on there, there's no reason why you can't have the next few doses. So this is why you follow through. So you're monitored, and your physician should talk to you about the risk versus the benefits. Next slide. There is one little devil out there, and there always is, isn't there? It's called ARIA, or amyloid-related imaging abnormalities. And what this is, they want to say it's a common side effect. So this is what we were just talking about with some of the swelling or some of the minor bleeding. But it can be fatal. So your physician should be warning you if you have symptoms X, Y, and Z, call me. Get your butt to an ER. So what we know is the disease can cause edema, which is swelling. It can cause microhemorrhages. These are real small hemorrhages in the brain. We're not talking something massive. And they can cause some iron deposits. We can see this on MRI scan. So here we're back to why we get those MRIs done. Next slide. And there's actually a schedule. You get 6 doses of the drug, you get an MRI. You get 10 doses of the drug, you get another MRI. You know, there's actually a schedule you follow for it. Now, there are a couple ions that are in the body. And what's weird about this is that they're in your body, you may have more of these. You can have these and not have any of the ions in your body, or you can have the ions and not have any of these. So we don't have an exact science here, but we are seeing that there may be a coalition. So they may ask for some additional blood work before they start you on the drug. But what we're seeing is some more of the hemorrhages. Now, this last one is really interesting. Excuse me. Microhemorrhages in the elderly population, about 6% of us have them. We don't even have symptoms from them. The MRI I had, and I told you I don't like MRIs, so I had an open MRI that I had for diagnostic, showed a microhemorrhage. So I didn't have any symptoms of it. So they can come and go. But if you have cardiovascular disease, so if you're a patient that has strokes, heart attacks, vascular disease, the incidents are between 50 and 80%. So your physician is going to want to have a good history on you and know how healthy you are and look at what the odds are of having problems. I'm not saying these drugs are not without risk, but believe me, a lot of those drugs we take out there have risk. Next slide. So how are they administered? Somebody had asked me that. These drugs are given IV. So it's in a needle that's inserted in your arm. Casenolol is given once every 4 weeks, and the infusion lasts about 30 minutes. The dosage on this drug is the same for everybody. Questions on that one? Where can it be given?
Is that forever? That you have to stay on that, every 4 weeks?
Every 4 weeks, as long as it's helping you.
I see.
The disease is still progressive, and we don't have a cure for it. So if you're not seeing a benefit from it, then why take the drug? So if you've had the disease for 5 years, you may not see a benefit because you're already past the early stage. Good question. I like that one. I'm going to remember that one. So where can these drugs be given? You're not going to be getting them from the pharmacy and take them home and giving them to yourself, are you? No, I didn't think so. Infusion centers or at a physician's office. I know my neurologists, they have an infusion center in their office. We have an infusion center over here on Continental just before La Posada. Now that doesn't mean you can get it there because they may be booked solid. So you may have to get on a waiting list, and meanwhile you're going up to Tucson to an infusion center. But you can end up getting these closer to home so they're not taking as much of your time. Next slide. Lequimbi, again, is administered IV. The infusion is over an hour, so it takes longer. This one is based on your weight. So you're given it 10 milligrams per kilogram of weight. So they're going to watch your weight. What they're looking for in the infusion center is, are you running a fever? Do you feel like you got the flu? Any nausea or vomiting or that headache we talked about earlier? You can have a reaction of a low or a high blood pressure, or you can have oxygen desaturations. So they're going to monitor. I guess that's why you can't have it at home, folks, unless you have a doctor living with you or a nurse. Yeah, you need to go to these places and have the professionals watching you. Next slide. Any of those things? What's your questions?
You haven't mentioned Rexulti.
Okay. It is not a disease modifier.
Okay, the reason that I bring it up, my wife is taking it. She took it in December. No improvement, no improvement, no improvement, no improvement. Come first
He's got a mic for you there.
Recording. There you go.
Yeah, we're recording this.
Oh, okay. Come the 1st of February, I walked in to see her. She was a totally different person.
Good or bad?
Good.
Oh, good. I'm not going to complain about that.
It is an extremely costly drug.
So are these.
And so, yes, and so are those. And as the progression through this month, she seems to be going back to
Where she was.
Before. She is like you. She is a nurse, an RN. She can be a pain, as I think you probably can too. But that's the nature of the beast. But it is just.
I like you.
It's just the idea that I expected when she was given that okay, when she reaches a certain point, and they told me it'll be 2 to 3 months before you see a difference in her. Well, it was 2 months. And at this point, I don't see a whole heck of a lot of difference between what she was before she started taking it and what she is now. It is not something. It's got to prove itself to me even more than what it proved itself to me when I first saw the difference in it.
Yeah. I would suggest having a conversation with your physician. Express your concerns to him that the drug doesn't seem to be as effective over time, and ask him what he thinks you should do. Should we keep taking the drug for another 4 or 5 months, or should we stop it, try something else? That is a conversation that is a little above my level. But I would be asking questions if it were me.
Yeah.
And you have a right to.
I have a meeting with Dr. Dean. He's the one who prescribed this for her. And diagnosed her with Alzheimer's.
Okay.
And I have an appointment with him in a couple weeks.
Okay, the other question is, how long has she had the diagnosis of Alzheimer's?
My diagnosis or the real diagnosis?
I'll take you for either one.
Well, because I saw my mother and my father both go through Alzheimer's. I would say that she had it in the early steps of Alzheimer's. Maybe 5 years.
Okay, so this is what I wanted. So this drug, we're talking about early stage. Would you guys say she was early stage? No. I don't know that these drugs would benefit her. I'm not saying you can't take them. But you're already at 5 years. The usual age frame for Alzheimer's is 10 years. It's wicked to live with that disease
Yeah,
for 10
that's
years.
what my dad was.
But that is the time frame. So at 5 years, you're past the early stages. They don't have enough information on these drugs. They've been out a year and a half to say, are they still going to be beneficial in the middle stage? If somebody was still on them and progressing to the middle stage, they might say, yeah, continue them. But we don't have enough proof yet.
Are there alternatives to
Not yet.
Rexulti?
Not, I don't know. That one is not, I don't know enough about those drugs. You got to take, I haven't practiced for almost 10 years. I went back and went through my books for this lecture. I would talk to a physician. I mean, that's going to be much better for you than anything else.
Yeah, I have to. Because I yesterday when I was in there, I couldn't stay.
Yeah.
Because she just gets.
And, you know, we all know that the Alzheimer's patient can be very hard to deal with. And, you know, we all can only take so much. Bless all of you that are dealing with it on a daily basis, because it's a rough road. It really is. Other questions?
I have.
Yeah.
How do you get someone to get diagnosed if you think they have it?
Bingo. The number one question. She's asking, how do you get the Alzheimer's patient to get diagnosed when they're there? I don't have Alzheimer's. Yeah, I think you might. I would talk to the physician who's caring for him. Have that physician make the recommendation that he see a neurologist. If you can get in that door, you might get some answers. Because they can say, well, you need this test, and you know, that can give you a diagnosis. And then you can look at treatment. But that's the other end of this problem, is getting your patient, your family member, to consent to having treatment. Because I don't have Alzheimer's, you know? Most people will deny it. I have a neighbor, my wife, his wife comes over all the time and talks to me because he won't do anything. And he's on drugs. He's on the symptom management drugs. He's not on any of the disease because he doesn't have a confirmed diagnosis yet. She can't get him there. That is a huge problem. A lot of our patients will listen to a physician before they will listen to us, their family members. So consider that. Talk yourself with the physician, tell them what you would like done, and then bring the patient in and see if you can get there. Because the physician says, I think you need a referral to a neurologist. You know, physicians are God. We'll do whatever they say, right? I won't tell you some of my stories. Okay. Good questions, folks. Any more? Okay, any of you who would like a copy of the slides, if you will leave a email address, I will email them to you. Oh, he can send them out too. He can be my secretary.
I failed today, but I'll do better in the future.
Does that mean I have to get you a gift for Secretary's Day?
No. Actually, not a bad idea.
Hey, he likes that
What about
idea.
Nurse Day? Is there a day to celebrate nurses too?
Oh yes, there's a whole week.
A whole week.
Yeah, we get a whole week. There's a week also for neuroscience nurses.
Okay. You get 2 weeks.
It's been a pleasure. And I'll be here for a while afterwards if somebody wants to ask me some of those personal questions that aren't relevant to the group. Okay? Thank you very much.
So thank you so much, Bonita. I really appreciated your coming, and apologies about the miscommunication on my part. I did want to let you know that when I was talking to Dr. Domer, Dr. Timothy Domer has been here several times to give presentations, and he's excellent. People really like Tim. He does a really great job. And he and I were talking back and forth about what he would do next month when he comes. And I contacted him and I said, well, have you given it any more thought? I've got a couple ideas for you. And he said, well, actually, he said, I was thinking about diagnosis and treatments of dementia and Alzheimer's. But I sent him Bonita's PowerPoint and said, you guys have got that covered. So here's the deal. He's going to be here next week, next month. And he said, I will be open for any questions people have. So if you have questions about Bonita's presentation, you can, by that
I'll
time,
be here
you can
too.
talk about it a little bit. You can think about that. Any other questions that you want to have? And the question that was asked about how do you get this loved one to come is a huge one, and he may have some tips for that as well. So
Is he a neurologist?
he is not. He's actually retired and more of a geriatrician. He's done a lot of work on Navajo Reservation, Hopi Reservation. So he's an interesting guy. But anyway, so that will be next month, and we have scheduled for May is the conversation about Alltech. And Alltech is the Medicaid program, Arizona long-term care system. And so this is how people who are in a long-term care situation, financially a very difficult situation, how the process they have to use. And that presentation is going to be 90 minutes.
Ooh.
Because the presenter said it takes 90 minutes to go through all of that information. And there's a lot of work that has to be done on that. Yes, ma'am.
Is there something in our area here, because I'm fairly new to some of what we're talking about, where there's a support group where you can just, rather than have a scheduled class, and I've looked at things that are available, but more on an informal basis where you're sitting with people that have a loved one, and you're dealing with certain things where you can talk more informally.
More like a drop-in thing.
Rather than a presentation.
Yeah.
Do we have anything?
The Stress Busters does have some content with it. It's a lot of support, but an open-ended drop-in one.
Well, La Posada agreed.
La Posada.
The first and third Thursday at 2:30 at their community events building.
Yeah.
Say that again.
First and third Thursday
Yeah.
at 2:30.
At 2:30. There you go. So which is why we have the second and fourth Thursday for our programs.
But
So-
Lynn Severe has one too.
And Lynn Severe has
Did you
had
say
some
what time?
with,
2:30.
2:30.
yeah.
I got it.
And I know Prestige was doing one also. Prestige has assisted living and memory care, but they also had
Well, I had
drop-in.
received this, but to me, being able to commit to 9 weeks straight and not having my husband know even what I'm doing.
Yes,
and,
right.
I can't
I
commit to that
understand.
right
I understand
now.
that.
We understand.
We understand that is one of the challenges with that program. But there are alternatives in the community for which we're hearing some of those. So
Yes, thank you.
anyway, yes, Bonita.
I just wanted to be sure I didn't leave you with the thought that the only one that can prescribe these drugs are neurologists. We live in a part of the country where you could be miles from a physician. Anyone with a license, that includes myself with my nurse practitioner, can prescribe these drugs. But what I'm saying is you need at least some of that follow-up with somebody that really knows what they're doing so that you get the right care. So it may be see the neurologist once a year and have the gerontologist or somebody like that follow through with the prescription and getting the medication. I just didn't want to leave you with that thought.
Thank you, Bonita, for that correction. Just one other thing, the other program that we do regularly is the Memory Cafe for loved ones who are experiencing memory loss and their caregivers. And so this is an informal time to get together and socialize. And that's next Thursday. No, 2 weeks. It's the second Thursday. She knows all the details. It's the Thursday. It's the 13th of March at 2. We say 2 o'clock, but come a little earlier, and now we're extending our time to 1:30. So anyway, that's a wonderful drop-in program.
And you get to meet people that may have your same situation.
Right.
So someone you can talk with.
It's a support community, and that's right here.
Yeah.
The church. It's a
Right here.
free program. The FEMA Council on Aging overseas, and we got a grant from them to run the program here. So PCOA has been a big part of our experience. So are there other things? Anything else? Thank you so much. If you're new, be sure you gave us your email address. I put you on the email list. I try not to load your inbox, but give you enough information on that. So thank you for coming today.
You're welcome.